Hello again, and welcome back to the RunPC Triage Tool training course. This is Module 2, the development of the RunPC Triage tool. Just to refresh key points from Module 1 before we move forward, the things that we covered there were that triage is a process where patients are prioritised based on their urgency of need. In palliative care, triage is complex due to differing goals, needs, and types of needs. Transparency and consistency are needed within and between services. And a standardised palliative care triage tool is applied after referral and determination of the patient's eligibility for specialist palliative care. It's not a prognostic tool. It doesn't negate non-clinical factors or ethical complexities, but makes decision-making explicit and reproducible. Today we're going to cover the three major studies that contributed to the development of the RunPC Triage tool. So our qualitative work, the development of the scoring system, and then the validation and generation of recommended response times. So firstly, looking at our qualitative work. We did a quick literature review of existing palliative care triage tools. And in green here is, in the green box is a list of the triage factors that other tools had incorporated or the studies had discussed. So starting from more obvious factors and moving on to more bespoke, we've got acuity of symptoms of the patient, psychological or spiritual distress, caregiver distress, phase of disease and nearness of death, performance status and adequacy of current care environment, requirement for daily subcutaneous medications or hygiene support, potential for a catastrophic event like a bleed or airway obstruction, length of time waiting for palliative care service to be available, and political ramifications for the hospice if admission is delayed. So our literature review really found that there was a lack of robust evidence base for the structure and content of these tools. The tools had been generally conceived either by individual clinicians or working groups of clinicians, potentially using a retrospective case note analysis, and there was one or two more robust qualitative studies. However, none of them had been successfully validated. The scoring system was either non-existent or non-validated, or had been validated but the validation had been hampered by poor face validity and inter-rater reliability. As there is no gold standard for palliative care triage, the tools were validated, or when they were validated against clinicians' gut feeling or tools that were not designed for triage, such as symptom assessment scores, which were actually measuring different things. So we really set out with this research question: how should the urgency of specialist palliative care needs be assessed and compared between patients? We had this practical aim which was to integrate the data to ultimately develop an evidence-based validated triage tool for palliative care. So the three studies each had a underlying question. So the first study, which factors are most useful for determining the urgency of palliative care needs? Study 2, how should each of these factors be weighted relative to one another? And study 3, when incorporated into a tool, can these weighted factors rank real-life referrals in order of urgency in a valid, reliable manner? So study 1, the qualitative exploration, we talked with 20 Australian palliative care clinicians and 3 bereaved caregivers in a mixture of focus groups and interviews. And you can see from the table here the breakdown of their profession, place of practice, gender, age, work setting. And I'll just draw your attention to the years of practice. So the mean number of years of clinical experience in palliative care was 14.7 years. So a very experienced group of clinicians participating in this qualitative work. And really that we found agreement across disciplines and settings regarding triage factors. So the 7 factors are listed out here, and we'll go through each of them in detail, but they're physical suffering, psychological suffering, caregiver distress or burnout, urgent and complex communication needs, discrepancy between care needs and care arrangements, mismatch between current site of care and desired site of care, and imminent dying. And of note, in the text box there, we didn't include performance status, that's the Australian Modified Karnofsky Performance Status, AKPS, or peacock phase, that's the phase of disease, palliative care outcomes collaboration. And I'll talk about that as we move forward. So just looking at each one in more detail with some quotes from the participants. So physical suffering of the patient is a fairly obvious one, and a nurse here saying, from a community perspective, the red flags are often easy. They've got out of control pain or nausea or vomiting or acute respiratory distress. Likewise for psychological suffering of the patient, the nurse saying their anxiety was such a big thing, it was just urgent for them. And caregiver distress. So an allied health clinician saying if a carer is really struggling, it's never going to work without the support. So those three are fairly straightforward and obvious factors indicating urgency. Urgent and complex communication needs. This is the first time that communication needs had been described in the literature as a triage factor. Making a case urgent. So this doctor's quote captures it nicely. So rather than allowing that person to be sent off for one more investigation and they're clearly dying, you might want to get them moved urgently to the palliative care unit to establish clearer goals of care and a way forward. If the patient is suffering as a consequence of inappropriate goals, then that's urgent. And our findings really were that the performance status is unhelpful in isolation. Performance status, as you would remember, had been included in other previous triage tools for palliative care. But a couple of quotes from participants here. So you can have any performance status and have urgent need, I think. You could be ambulant and have terrible pain at home. There's an awful lot of people out there in nursing homes who have terrible performance status who are perfectly comfortable and don't need admission. So I'm not sure that's going to be very helpful. And another doctor here saying it's the rate of change which is really important. Somebody is going along all right and then suddenly goes whoosh. It's that rate of change when it's suddenly changing that's often when people need help. So we created a more dynamic triage factor here, taking into account all the conversations in the focus groups. And this is really the discrepancy between the care needs and care arrangements. So you could imagine a patient in the community, maybe a 70-year-old man with pancreatic cancer, and his care needs could mean bathing, dressing, medication administration. His care arrangements could be fine if he was living with adult children and a broad support network with a GP on call, but really quite different if it all falls to his frail elderly wife. So a nurse here saying, is it a good GP or is it a rubbish GP? Do they have a lot of support, family support, or do they have none? The support they have in different ways is of huge importance, and sometimes people with high symptoms who are well supported maybe won't end up as urgent as someone with no support. And another nurse saying it can be urgent to get in and set it up, make sure you've got emergency medications, the bed, everything else you might need to enable them to stay at home. And you could switch that around too with the urgency of someone who's in an acute bed in hospital who's deteriorating and wanting to go home. So the response, the categories really to respond to this would be that there's no discrepancy, there's a current existing discrepancy, or there's an impending discrepancy. So you can see that the situation's changing, they're deteriorating, and their care needs are soon going to exceed their current care arrangements. Finally, the last two triage factors were desired site of care and imminent dying. So it's probably helpful to discuss this in the context of phase of disease. So the phase of disease for the patient is whether they're stable, unstable, deteriorating, or terminal. These are the palliative care outcomes collaboration categories of phase of disease. And participants in our qualitative studies really described that these categories were unhelpful in isolation when trying to determine how urgent someone was. So a nurse here saying, what are the problems? What aren't we managing? And what can you do for us to help get this person more comfortable or deal with the family or psychosocial support? So it's more around those problem severity scores rather than phase of care. So our participants described the unstable phase really being characterised by severe problems in at least one or maybe more of the other domains we've already mentioned, like physical suffering, psychological suffering, caregiver distress. So there's something that's severely going wrong that would be captured by those other domains. And is inherently sort of by definition urgent. The deteriorating phase was characterised by moderate problems in one or more of those other domains, or an impending discrepancy between care needs and care arrangements, which we've already discussed. Stable disease is almost always not urgent, and the only exception they described was the terminal phase, which really they viewed as core business regardless of problem severity, and identified this as a key trigger point for mobilising resources. And this was linked to the site of care for the patient, but when we teased it out, they really were two separate issues of, was the patient where they wanted to be? Were they distressed about where they were? So were they in hospital and really wanting to be at home, or were they at home and really wanting to be in hospital or hospice? So that's number 6, desired site of care, and then whether or not the patient is imminently dying is number 7. And a nurse here capturing them both. If people are saying, I want to go home to die, and they're getting more terminal, then it's a no-brainer. So once we had these 7 triage factors from the qualitative work, we needed to work out a scoring system for them, how each of them should be weighted against each other to determine a final kind of triage score. And to do this, we conducted a discrete choice experiment, which is used in economics and marketing, and you'll understand the concept when you think about your weekly food shopping. So it's a quantitative research tool, and in a discrete choice experiment, or DCE, a series of hypothetical scenarios are described by the attributes of interest, so in this case the triage factors. Participants state their preference within each pair, and the response patterns determine the relative importance of each attribute and thus provide the scoring system for the triage tool. So you could imagine it when you're doing your food shopping, you're going to buy some wine and you're choosing between this 5-litre cask of fairly average quality or poor quality wine versus 750 mils of a good quality wine. So there'll be a different price point for each, and there may be some people who say, I'm never buying cask wine, I only ever buy bottled wine. But there are other people who, if perhaps the price point was a real bargain for the cask wine, they might be willing to compromise on the quality of the wine for getting that value. And so it's similar there. So the hypothetical scenario is the two different products with their attributes of interest. So the volume, the quality, the price, the packaging, the convenience, those are the factors that might describe it. And everyone's going to have a different point at which they'll be willing to compromise. And so for us, what we would be doing is these hypothetical patient scenarios, or one patient versus another, that are described by the triage factors. So one patient with severe pain, one patient with moderate anxiety, for example. And our clinicians participating in the discrete choice experiment would have to pick one patient over the other. And when we do this with multiple scenarios, multiple clinicians, multiple decisions, we can look at the response patterns to determine the relative importance of each attribute and how much that triage factor is influencing the decision making of the clinicians. So here's an example from the discrete choice experiment. So these two patients have both been newly referred to you today. Thinking of the service that you identified as your primary setting, so that might be inpatient palliative care, community palliative care, or hospital consultation liaison palliative care. Imagine this is the only service available, so you can't sort of send one of them to the emergency department and tend to the other one. You can only pick one patient. So which patient will you admit to your service or see first? So we've got patient A, who is Mrs. Smith, having moderate pain and severe anxiety. Her caregiver is extremely distressed. She understands her prognosis and has clear goals of care. Her care needs are increasing and expected to soon exceed current arrangements. She is expected to die within days. and she is currently in her desired site of care. Excuse me. And we're comparing her to patient B, Mrs. Jones, who has no pain but moderate anxiety. Her caregiver is not distressed. She urgently wants to discuss her prognosis and make important decisions. Her care needs are being adequately met by current arrangements. She is also expected to die within days and is not currently in her desired site of care. So when we distill the cases down to just those triage factors, you can see the complexities of the decisions. And this decision, Mrs. Smith versus Mrs. Jones, is quite challenging. They both have pressing needs, but they're quite different. And we might have found in this particular pair during the discrete choice experiment, maybe 50% of participants would have picked A and 50% picked B. It's a very difficult decision, and maybe there's not really a right or wrong answer. But perhaps if one of them had several less things going on and the other one had severe pain or was imminently dying, we might have found now 90% of participants picked A over B. So this is how the discrete choice experiment worked. And I guess it's just another point at which to just note that these decisions are happening anyway all the time. And it might be that when you get two patients like this, in a sense, it doesn't really matter which one you take first. They're both fairly urgent, but we haven't currently been using a transparent, reproducible, systematic way of assessing the two of them. We had over 700 clinicians worldwide participate. You can see there the breakdown of where those clinicians were based, so mainly Australia, New Zealand, North America and Europe. And again, a very experienced group, so the median years of palliative care experience was a decade. And you can see as well the breakdown of the occupation and metro versus regional, and where they were working in terms of a inpatient community or palliative care hospital consultation service. And here are the findings for the 7 triage factors. So it probably becomes more clear on the next slide, but this is just the raw data. You can see that the physical suffering or distress of the patient, when that was severe, that was hands down the most influential factor, more than double any of the other factors. And then the patient imminently dying, the patient being psychologically distressed, or the caregiver being distressed, were also quite strongly influential. But each individual factor was independently and statistically significantly influential on decision making, and that really just affirmed the importance of our qualitative work, that each of the 7 factors that came out of our qualitative work were really important in how clinicians approached assessment of urgency. So the final tool you can see here, it has an emergency caveat at the start. So we just, in our qualitative work, there was some discussion in the focus groups about this, but we wanted there to be some safety around if there was a medical emergency, suspected or impending, like a spinal cord compression, superior vena cava obstruction, airway obstruction, seizures, acute bleeding, or a psychiatric emergency like an agitated delirium or suicidality. So if the patient or caregiver might want investigation or treatment of one of those things, and that's what you think is going on, really regardless of the score, the case needs to be discussed with a senior clinician immediately. And it might be that in fact the emergency department is the best place for that patient, or that there needs to be special arrangements put in place for them, even if they don't score particularly high on the tool. So that's there to do first. And then you can see, as I said, number 1, the physical suffering or distress of the patient. If that's in the severe category, it gets 32 points, which is more than double all the other factors. And then the next highest is the psychological or spiritual suffering or distress of the patient, and the patient being imminently dying, number 7. And then the caregiver distress, which is number 3, and then the others that you can see there. So Then in terms of the response options, you can see that unknown, nil and mild all score 0. And the reason for that really is that our investigator group felt that the clinical difference between nil and mild would not have a large enough impact on a clinician's assessment of urgency to justify the way that adding this additional level to the triage factors would have made the statistical analysis of the discrete choice experiment much more complex. So adding in nil versus mild would have meant that the discrete choice experiment would have been a much longer experiment for participants to undertake, and or we would have needed to recruit many more participants. As it was, we were very pleasantly surprised we had more than 700 participants, but we certainly weren't expecting it to be that successful. So at the time that we designed it, we decided to collapse nil and mild together and just call them both nil. But to maintain the face validity of the tool, we needed clinicians to be able to select between nil versus mild, so that those two patients could, patients with mild symptoms could be differentiated informally, and to really help clinicians to trust the tool and feel that the tool was capturing the important information. So we have a nil and a mild option, even though they both score 0. And then in terms of the unknown category there, so referrals with missing data are problematic. It's not uncommon to receive a referral where the referrer perhaps doesn't know anything about how the caregiver is getting on, or perhaps doesn't really have much of a grasp of how the patient is coping psychologically. But the validation study, which we'll talk about shortly, really showed that assuming the worst and allocating maximal scores to any unknown factors actually decreased the reliability of the tool. So again, to maintain the face validity of the tool so that clinicians didn't have to answer that there was no problems if they didn't actually know that there were no problems, rather than just having the nil and mild options, we added the unknown option, and that can serve as a prompt to the clinician to seek out further information with a plan to re-triage the client. But there really wasn't any scientific justification to giving that a score other than 0. So that's the final tool there. And I just wanted to discuss briefly the dominance of the physical suffering. So as I've said already, it really was more than double every other factor. And to try to understand this better, it's helpful to look at our qualitative work, the study 1, which suggested a hierarchy of clinical problems. So a nurse saying here, we've always been taught that to try to manage the physical symptoms will then allow the person to be able to embrace some of the other stuff that's going on. So if you don't deal with the severe pain or the severe nausea, then you're not going to be able to deal with the communication issue or information issue or psychological issue. You really need to deal with the physical first. And another nurse saying, we would probably respond quicker to someone with pain and nausea because you can fix it with an injection, and there's no point getting out there quickly if we can't do much when we get there. So really that's just around kind of the value of resources, and if prioritizing someone, you want to be able to make, if you're going to prioritize them, you want to make a difference quickly, and so perhaps some of those physical things are the quicker fix, or at least to be able to get started on trying to fix them. So some of those things perhaps help us to understand how the physical suffering really scored so highly in the discrete choice experiment. So that's the scoring system for the RunPC triage tool. And finally, just looking at the recommended response times and validation. So in validating the tool, we had some logistical challenges. So we could look at implementing the tool at Health Service A and Health Service B and comparing, did people get comparable scores? But then we don't know, is it really the same population? I mean, perhaps the patients being referred to Health Service A are actually more urgent. They have a different referral pattern to the patients at Health Service B. And likewise, if we got clinician A to apply the tool and then clinician B to apply the tool, just logistically in clinical practice, it's very difficult to get two clinicians to assess the same patient at the exact same time. As I told you as I pointed out in Module 1, often palliative care referrals are corridor or phone conversations, and the triage officer gleans information by probing with questions to the referrer. So it's not real. We would have needed a much bigger packet of money to make it feasible to double up the triage officer in real practice, to be there, to have two people there involved in that conversation to glean the same information at the same time. So that really posed a problem for us in trying to validate the tool. And this is what we really learnt on reflecting in our literature review, what other researchers had difficulty with in the past. So what I did was to gather a single pool of non-identifiable but authentic patients. So I gathered from a community service and an inpatient service consecutive real life referrals, and wrote them into short paragraphs of information that I then de-identified. So it really was authentic in that there was information missing sometimes, or instead of a referrer saying, oh, this person has moderate pain, they might say, well, they're taking this much medication and they're needing a top-up medication every few hours. That's the type of information that we are really given in real life, where we would have to try to interpret it a little ourselves. So those are the vignettes that I gathered. And in part A of the validation study, we had the Run-PC triage tool applied by palliative care intake officers. So these were people whose normal job was to assess and receive the new referrals. And by getting the same clinician to apply the tool to the same vignette on two different occasions, a few days apart, we could then test intra-rater reliability. So does the tool perform the same way by the same person on different occasions? And by comparing one triage officer to another on the same patient, we could then determine the inter-rater reliability. And then part two, we also had a panel of expert palliative care clinicians give their opinion on the same set of vignettes, and we use this as a reference standard, given that there is no gold standard for palliative care triage. So this was used as a reference standard, and we compared when the palliative care intake officers applied the triage tool, that would have put the patients in order of priority according to the tool, and we compared how similar is that to the order that these expert palliative care clinicians put the patients in order of urgency, and so thereby we can work out the convergent validity. The participants in the study, you can see here the breakdown of gender, age, profession, work setting, and years of practice. So as expected, the people in the role of intake officer in part A were less experienced than those who were our expert panel, who had a median of 20 years experience in palliative care. So the study results, so the intra and inter-rater reliability were both moderate, and you can see the numbers there. I won't read out, but all basically falling in the moderate range. And when we looked at the individual items or domains of the tool, the reliability was slightly lower for the psychosocial or the novel social domains, which really just pointed out that training like this module today, the training needs to make sure it explains properly those novel concepts, like the discrepancy between care arrangements and care needs. So terms and concepts that perhaps people are not as familiar with. But moderate intra and inter-rater reliability is really comparable to palliative care tools that are accepted in common practice, like the Peacock tools of problem severity score and phase of disease. And then in part B, the correlation of how the triage tool ranked the patients as compared to the expert opinion, and that was moderate to strong. So not as good in the hospital consultation setting, but in inpatient and community practice, really the tool enabled those less experienced palliative care intake officers to rank patients in a very similar way to how this expert panel would rank them. So very pleased with that. And this really just shows the correlation of the expert opinion with the tool scores. And so this is how we generated the cutoffs for each any given score. So the expert panel were asked for each of the vignettes to decide, would they consider this patient routine or non-urgent, urgent, or crisis. And then we looked at the tool cutoffs and saw that actually the scores generally correlated to that. So you can see there in the inpatient setting it going from blue to green to yellow to red in general. The one that doesn't work so well is the one in the middle there in the hospital consultation setting. And this was really because there was quite a lot of variation in opinions about what the categories should be or what the cutoffs should be in the hospital consultation setting. So, for example, many clinicians felt that in the hospital consultation setting, all referrals should be seen within 24 hours regardless. That should just be the policy. So therefore, those categories of 24, 48, 72 hours really had less meaning and there was a lot less agreement. But you can see with inpatient and community, there's a general pattern there of urgent to less urgent according to the score on the tool. And that's then how we made like a best fit of the recommended response times. So you can see for inpatient and hospital consultation, the top two categories there are different scores for those time categories, and in the community setting there's slightly different time categories, so it goes 24 hours, 72 hours, 7 days, 14 days, really reflecting the lower acuity in the community setting, and the scores there. And I guess I just wanted to point out that it is quite hard to score high on the tool. So anything over 50 is a crisis in the inpatient setting. Anything over 30 is a crisis in the hospital consultation or community setting. So in conclusion, from Module 2, the RUN-PC triage tool is an evidence-based, reliable and valid instrument to prioritise the urgency of palliative care needs. The RUN-PC allows routine and reliable collection of textured clinical information about the patient prior to admission and information about the caregiver also prior to admission. So really, this is new to be able to characterise the referral population in this way, and really gives us a lot of insight into issues like who dies on the waiting list, who ends up accessing an alternative service such as the emergency department. What is it about those patients that perhaps we could respond to better? But we're really getting much more clinical information about even the patients who we don't end up seeing, which we haven't been able to in the past. And this really then enables us to systematically measure and then address these missed opportunities. The new characterisation of referral population enables increased transparency, efficiency, standardisation and equity of access, and responsive staffing and long-term service planning. So really, around your staffing levels, but also the skill mix of your staffing, when you know more about who's being referred and perhaps where some of those missed opportunities might be. Further iterations may be useful in future to refine the tool, but this is a great starting point for an evidence-based tool for palliative care triage. So thank you so much for your time again today, and I want to also just again thank my co-investigators for this work and my funders, the State Government of Victoria, the Bethlehem Griffiths Research Foundation and St Vincent's Hospital Melbourne Research Endowment Fund. And that concludes Module 2. Thank you so much.